Good morning, friends. On behalf of the buyer, I welcome you all to this session, which is by buyer itself. And this session, we have a lot of topics, as well as we're going to have a panel and discussion. So I do find here Dr. Mahesh Anmungam and Dr. Hemant Murthy, and who else is there out of the panelists? George is there. Yeah, yes. And so I think Ashish, I saw somewhere, he might come here. So because the time, since we have a tight timing here, so Dr. Lalit is going to join us shortly. He's busy in the other hall. So I think Dr. Ramesh is here, so we can start with the first talk. What should be the first line treatment in DME patients? So Dr. Ramesh, please.
Yeah. Thank you so much. Thank you to Bayer for giving me this opportunity. And the topic of today is quite interesting. What should be the first line of treatment in DME patients? And we know that the vision problems in diabetic retinopathy is basically involving macular ischemia, diabetic macular edema, TRD, and vitreous hemorrhage. But we'll be focusing on something which is very common in diabetic retinopathy cases, that is the diabetic macular edema, which happens because of the breakdown of the inner blood retinal barrier, which leads to leakage and fluid accumulation in the inner retinal spaces, mainly from the microaneurysms and also from the increased capillary network or capillary permeability. VEGF and placenta-induced growth factor, that is the PLGF, they both drive the development of macular edema, especially in vascular diseases, mainly the diabetic retinopathy and retinal vein occlusions. And these VEGFs, they are responsible for activation of the microglial cells and then subsequently chronic inflammation and RP cell damage. And the VEGF is also important in breaking down the blood retinal barrier, which causes the vascular leakage and subsequently the development of the macular edema. So both VEGF-A and the placental-induced growth factor, they act through the VEGF receptors to play a critical role in the development of edema, the increased permeability, increased inflammation, and subsequently the neovascularization. So it is actually the increased permeability which happens because of the VEGF-A and the placental-induced growth factor, which were responsible for the development of the macular edema. So thus the treatment of macular edema would be following a diabetic retinopathy would require the inhibition of these VEGF-A and the VEGF-B and the placental-induced growth factors. And aflibercept is the only drug which blocks the VEGF-A receptors and the PLGF. And you can see here, in comparison to the other drugs which are the ranibizumab, brolucizumab and faricimab, aflibercept is the only drug which blocks against the VEGF-A and the PLGF, and it does not block the Ang2 receptors. What's also important is that the half-life of the drug is much more compared to the other anti-VEGF molecules. Now, let me just talk about briefly about faricimab here, because it's important, because people are going to talk about faricimab in the near future. And what faricimab does is it's basically an Ang2 receptor blocker and a VEGF-A receptor blocker. So what you need to understand is that the Ang1, which is actually a good molecule, it's a good molecule because it helps in maintaining the vascular integrity and thereby prevents the vascular leakage from happening. But when there is increase in the VEGF, when there is increased production of the VEGF, the Ang2 receptors, they get activated, and then they cause the pathological situations where there is a stress on the capillary permeability, and therefore there is increased leakage. So it is the increased or the elevated VEGF levels which are going to drive the Ang2 production and then subsequently the neovascularization and the capillary permeability. This is the important slide which tells you that when there is a low VEGF, it is the Ang1 which is present and which is responsible for an intact blood retinal barrier. But when there is a high VEGF, it is the Ang2 which comes into play, and it causes the breakdown in the blood retinal barrier and subsequently the development of the macular edema. So when you look at from a clinical perspective, it is a low VEGF state which can be achieved by effectively suppressing the VEGF with a long-acting anti-VEGF molecule such as the aflibercept, and this may reduce the potential therapeutic value of the added Ang2 blockade. Also, The role of faricimab, we have a lot of trials which have spoken about it, the Yosemite and the Ryan trials, which have actually spoken about the role of faricimab in DME and neovascular AMD. But the contribution of this Ang2 inhibition in the development of macular edema is still not very well understood. So we really don't know how much Ang2 actually plays a role in the development of macular edema, especially in diabetic retinopathy. So aflibercept should be considered as the first choice of anti-VEGF in the DME management. But in real world setting, is aflibercept the first choice? That is something which we need to answer. And what we did is we just looked at our data in the last 1 year, that is from 4th May 2022 to 4th May 2023, and we found that we gave around 674 Eylea injections or aflibercept injections in 320 eyes, and only 25% of these eyes were having diabetic macular edema. So we gave very less number of patients with diabetic macular edema aflibercept as the treatment. And out of these 79 eyes, it was only 29 eyes who received aflibercept as the first line of therapy. That means we are actually giving less than 10% of the patients aflibercept. This is the real world setting. This is the fact which I'm going to tell you. But let's understand what the reasons for this mindset is. Why are we not giving aflibercept or an Eylea so frequently? So that's the reason is because we have a lot of trials which have spoken about the various ways you can manage a diabetic macular edema. In diabetic macular edema with good visual acuity, that means when the vision is between 20/30 and 20/50, we feel that any anti-VEGF is effective. That is what the protocol T of the DRCR net tells us. We reserve aflibercept for patients who are having visual acuity less than 20/50. That is again the protocol T which tells us. Patients with early DME, where you have an early center involving macular edema, where the visual acuity is better than 20/25 or equal to 25/25, the protocol V of the DRCR net tells us that observation is a good enough treatment compared to aflibercept. We reserve aflibercept only for patients who are not responding to other anti-VEGF molecules. DME is treated on a PRN basis and not on the loading dose basis, which we usually treat it for AMD. We believe that good metabolic control alone will reduce the need for injections in DME. We reserve only for patients aflibercept for patients who are unlikely to come for a monthly follow-up and who require a longer duration of action. And we all the time we believe that the aflibercept is not affordable to the patients. So let's look at each myth and then try to counter those myths with the clinical trials which have been recently published. So the first myth which we have, it's not a myth per se, but it is aflibercept is effective in DME with visual acuity less than 20/50. So this is the data which comes from the protocol T, or the subgroup analysis which comes from the protocol T of the DRCR net, where you can see that for patients who are between with the baseline visual acuity between 20/30 to 20/40, the visual acuity, the gain or the ETDRS letter gain is almost the same irrespective of the choice of the anti-VEGF molecule which you use. But when the visual acuity falls below 20/50, you can see that there is a huge difference between aflibercept and the other comparative molecules which you have, where aflibercept actually achieves around plus 19 ETDRS letters compared to an bevacizumab or a ranibizumab, which achieves around 12 and 14 letters respectively. Now let's look at this in detail, and when you look at the entire cohort of patients, irrespective of the baseline visual acuity, aflibercept is still much better than the other comparative groups. But what you need to understand is the number of patients who require focal laser in patients who are being treated with the other anti-VEGF molecules. So you can see that patients who are treated with aflibercept, they require much lesser focal or a grid rescue laser treatment compared to patients who are treated with bevacizumab and ranibizumab, and this was a significant thing which we need to look at. So the first take home from the first myth which we get is that aflibercept should be the first choice with any baseline visual acuity. It is effective in 20/50, yes, agreed, but it is also equally effective in patients who are having vision between 20/30 and 20/50. Now the second myth which we have is patients with DME which have a very good visual acuity, and when we say very good visual acuity, we are telling about visual acuity which is equal to or better than 20/25, and where our understanding is observation is a good enough treatment compared to aflibercept. And the reasons are because of this data or this charts which come out, which says that the 5-letter loss is equal in both the groups, the 10-letter loss at 2 years is equal in both the groups, and the 5-letter gain is equal in both the groups, and therefore we conclude that observation is not inferior to anti-VEGF or aflibercept in the protocol T, in the protocol V study, or even in these studies. But what people don't look into in detail is the number of patients who are reaching the visual acuity of 6/6 with aflibercept injections. And you can see with aflibercept, you have almost a 77% of patients which are who are reaching the 20/20 or greater than 84 ETDRS letters compared to observation group. So this is a very, very important point, that aflibercept is means observation should not be considered as a treatment. It should be aflibercept should be considered even in patients with good visual acuity. Again, look at the change in this subfield thickness or the retinal thickness, and you can see at the end of 1 year the thickness reduction is much better with the aflibercept molecule, and even it is being maintained at the end of 2 years in these cases. Now let me show you 3 cases which we found, and where the patient's visual acuity was ranging between 6.6 and 6.9, and this is how the OCT patterns were at presentation, where you can see most of them had central involving diabetic macular edema, but the case 3 had a much significant amount of central retinal thickness compared to the other 2 groups. And the first case was observed, the second case was treated with topical NSAIDs, and the third case was treated with injection of aflibercept. And you can see the response which you are getting at the end of 1 month following the treatment in these cases, where you can see that there is a complete reduction in the macular edema with the aflibercept injection. So the second take-home point which I wanted to give is that it should be considered also as a first choice in patients with very good visual acuity, unless there are some other factors which need to be taken care of. The third myth is that aflibercept should be reserved only for patients with poor response to other anti-VEGF molecules. That is, we always try to keep aflibercept as a drug or a brahmastra when nothing else is working, no anti-VEGF molecule is working, and that is the time when we try and use aflibercept. And yes, there are papers which support this, which clearly say that in patients who are unresponsive to previous anti-VEGF therapy, aflibercept is a better option, and it helps in achieving an improvement in both the functional and the anatomical outcomes. So what we found with the 3 things is that it is useful in treatment-naive cases, and it is also useful in treatment-resistant cases, and therefore aflibercept can be considered in either of the 2 situations. The fourth myth is that DME is not AMD. AMD is something where you need more loading doses, whereas DME is treated on PRN dosing. And this is where we need to understand and explain the importance of early and intensive therapy. And the best way to understand early and intensive therapy is the protocol T results of the DRCR net, which basically compared the 3 anti-VEGF molecules, the aflibercept 2 mg, the ranibizumab 3.3 mg, and the bevacizumab 1.25 mg, and where at the primary endpoint you looked at the change in the visual acuity from from the baseline to year 1 in these cases. The protocol T also had a very proper regimen of retreatment. There had a very strict regimen of retreatment of how you treat these patients, when the macular edema is there, when do you inject, when do you defer treatment. They had a very strict protocol. Now let's look at the results which come out of the protocol T, and you can see this very clearly. At the end of 1 year with aflibercept, the visual acuity gain when you are giving monthly injections is around 18 letters or 19 letters, which is even sustained at the end of 2 years when comparison to the other anti-VEGF molecules, that is the bevacizumab and the ranibizumab, where the visual acuity gain is much lesser. But what happens in patients who have a better visual acuity? The visual acuity gain is almost similar, but it is still better than the other anti-VEGF molecules. Let's look at the central retinal thickness reduction. The reduction is much better with the aflibercept molecule at 1 year, and also at the end of 2 years, where it is more superior compared to the other anti-VEGF molecules. Now, patients treated with aflibercept experience a significant or considerable reduction in the central subfield thickness regardless of the visual acuity. So this is a very important slide which tells you that irrespective of whatever the vision is, the central subfield thickness, when you are treating early and intensively at a monthly interval with aflibercept, the reduction in the macular thickness is much significant, much better than the other injections or the other anti-VEGF injections. Also, the number of injections which you require with early and intensive therapy is much lesser at year 2. So it is very important when you are treating year 2 aflibercept, the number of injections which you require with aflibercept is much lesser than the other anti-VEGF molecules. Now this point is again further confirmed, or further you can say it is fortified with the VISTA and the VIVID and the VISTA studies, which basically compared the aflibercept at the 2 weekly four weekly dosing and comparing the 8 weekly dosing against the sham group. And again, you can see that when you treat these patients early, at the first month itself, there is a significant improvement in the ETDRS letters. Around 5-letter ETDRS improvement is happening. And when it comes to at the end of 1 year, there is a 11-letter improvement, and then which is being sustained over a period of 3 years. And this is the same which is being shown with the Vista studies as well. And this data tells us that around 80% of the patients, they show more than 5 ETDRS letter improvement when they are treated with monthly, at least 5 initial monthly dose therapy. Now, this is important because these improvement in the visual acuity is sustained over a period of the second year and the third year as well. So patients who are treated early, the visual acuity gain is being sustained over a period of the second year and the third year as well. So intensive therapy in the first year itself with aflibercept, it shows significant visual improvements that are maintained over a long-term period, especially in year 2 and year 3. Now, what happens when you treat late? What happens? This is a very important thing. So when you look at the red box where these are the patients who were in the sham group, when they were treated late, where they were not treated initially and they were treated after a period of 2 years, and you can see that the visual acuity which was improving in these cases were hardly anything. So delayed treatment did not achieve significant ETDRS visual acuity improvement. This is further fortified with our study itself, which came from the NN group, where what we said is about the retort study, where we said that patients who were treated for more than 6 months later, they had the worst visual outcomes and they required more number of injections. So this is something which we have published as well. So delaying the anti-VEGF treatment may lead to irreversible loss of vision. So the fourth take-home point which I wanted to tell is the early and the intensive therapy is definitely superior to late and incomplete treatment in DME. The fifth myth which we have is that it's not cost beneficial, and this can be addressed by the ILIA for You program, where you basically, these are patient support programs where you initially pay for the 2 injections and the remaining 3 injections get free of charge. So when you have good patient support programs from the company itself with long duration of action and longer treatment free intervals, aflibercept turns out to be cost effective as well. The sixth myth which we have is that when you have multiple injections, you end up with multiple side effects. And when you compare it with the Kite and Crystal study, you found that the number of injections or the number of side effects, ocular adverse events were much lesser with the brolucizumab group. And therefore, the sixth take-home point, I would say it is a safe drug. So to conclude, I would just say that aflibercept should be considered as the first line of treatment in DME because ILIA is effective. It gives a Yahoo kind of an effect. It is long lasting. It seems to be economical, and also it seems to be all right and safe at the end of the day. Okay, so thank you very much. Thank you for your
kind. For nice presentation. I think we'll have a discussion on this, and the first question which I would like to put forward to here, I think we have all the panelists now, is what determines the first choice as far as the anti-VEGF in DME is concerned? I start with Dr. Mahesh Shanmugam. Mic, please. Is there a mic there? You have to give a...
The only thing that stops people from using it would be the initial cost. Otherwise, like aflibercept possibly is better in every other way. So given a choice, I would prefer starting the patient with aflibercept.
Yeah, anybody else? Yes, Hemant.
Yeah, I would agree with him. See, our choice has been driven more the patient's requirement and the economical factors. But let's say if that is taken off, especially in insurance patients, aflibercept would be the...
Ashish and George and Ashish. George.
Yeah, to the point which he raised, Ramesh raised on recalcitrant cases. It was in the beginning. Now it is no more, that time the cost was the major issue. Even for now, there is no, I mean, naive is, affordability is the only thing which determines whether what is the first line. There is no doubt the safe and effective molecule is aflibercept currently. And unless we have more, more potent ones with safety and longevity, so to reduce the burden, DME we need to treat for at least 2 to 3 years. And this loading dose, it's come from the DRCR protocol. That is what I wanted to start. It is not like 5 injections or 6 injections until the macula dry, and plus maybe one more, so that the visual acuity maximizes. So because that is the best current protocol to reduce the number of injection rather than treat and extend. So most of these trials have used, including Vivid Vista, everything use that protocol. So I would rather stick to DRCR protocol than treat and extend.
Dr. Ashish, anything?
Nothing, sir. I think what Dr. Mahesh and he said exactly the same.
I think that's the major thing, affordability. Otherwise, yes. Yeah.
Because the duration of effect is so long that the number of visits and number of injections also comes down. So our treatment burden goes down with a drug like aflibercept.
Yeah, but what has come out is that the problem here is the cost. You would like to use the best drug.
Initial
You
cost.
want to use, and
It's only the initial
perhaps the
cost.
use has gone up. Many of us are using as a first line now, since the cost, it has become more cost effective. So that is what basically, and durability, of course, is subsequently what will come. I had another question to the panel, which is, I think one of the thing raised here is about observation and good visual acuity and giving the injection. So again, I start with Dr. Mahesh. So do you give injection, or I think these are some of the important issues perhaps where we...
At the present moment, I'm not giving injection in very good vision, but that's like if the patient has been followed up by me. And if the patient is presenting to me for the first time with good vision and edema, I would probably not inject right away, but see the patient on a closer interval. So about a month later or 6 weeks. And if I find that edema is going up and the vision is still the same, I'll probably start injecting, but I don't start injecting right at the initial moment when I see the patient with good vision.
Dr. Hemant, yeah.
I would also look into the systemic status, and if that needs to be corrected, I would probably go for that. And I also look about the reliability of follow-up. So there are also that reliability issue in some of our patients, especially if they're outstation and they're unlikely that they're going to come for follow-up. Then I need to take a decision on it. But I think I always treat the patient by the vision, primarily, not by the OCT.
Yes. Dr. George?
I would observe the patient, then injection. You have to, risk-benefit ratio has to be given to the patient. If this 20 by 25 vision is actually 6 parts, that is better than 6/9. So the patient has to understand that these injections are not one time, it has to be multiple. If he understands the concept, then it has to be in discussion with the patient. Otherwise, I'll observe with time, because we are not losing the vision. We are keeping the patient on follow-up, and at any time, he also understands, then start the injections like the same protocol what he discussed.
Yes.
If it comes to 6/9 or...
Dr. Ashish, yes.
Means, yeah, I always observe these patients, because we know the data that even best of the best trials, even best of the trial data, at the end, after 2-3 years, you have 30 to 60% of patients having persistent edema. If you have that kind of IRF staying for so long, so it's unnecessary that we treat patients with good visual acuity.
Great. Yeah. Yeah, that he has shown that trial, but at the same time, that is what. So what I would like to say here is, which has come from all the panelists, that don't treat the OCT. Please don't treat OCT. We are treating OCT these days. That is where the crux of problem is. So treat a patient. I think somebody mentioned about the metabolic control and other things. We have to look at those things rather than just looking at OCT.
And it's not just the cost; it's also the risk. There is a risk of endophthalmitis.
Yes, that's what I'm saying.
In a
so
6/6
many things.
eye.
Yes, very true, very true. I think we still have a little time there. I think I'm going off the track here. I think he mentioned topical NSAIDs. How many of you use topical? Has they got any role? Quick pick this thing, Mahesh.
Not in addition to the anti-VEGF agents, but if the patient, like Hemant mentioned, the systemic control is not there and I want the patient to go and come, or the patient doesn't want injection, I probably try NSAIDs. But I think there are studies to say that NSAIDs have shown some effect on the edema.
Yes.
I would,
Yes. Just a minute.
no, I would probably just look at it, especially in a patient who has just undergone cataract surgery and having some edema where you are doubtful whether it is post-surgical or is it. Other than that, I don't use it.
Okay. Yes, George.
If I decide to observe that patient for whatever reason we discussed, then I put the patient on NSAIDs.
And Dr. Ashish. Okay. Dr. Malika. Yeah. Okay. Thank you. Thank you very much. I think since the time is short, we'll move on to the next talk here. This is going to be, again, this is going to be the real world experience in DME. And Dr. Malika is going to give this talk. Dr. Malika, please.
Good morning, everyone. It's nice to.
Dr. Raja, so you are going to moderate both real world things. Why don't you come over here?
I'll be speaking only on my experience with cases and not anything else. See, though it's a Bayer session, I think ultimately we are only discussing what is best for our patient, because ultimately that's the only thing which counts. Is it happening? Okay, can you convert it to full? कर सकते हैं आपको आता नहीं है तो छोड़ दो फिर चलो छोड़ो okay so I'll be talking about my own experience. So the previous speaker has already touched upon the strength of effect and the long duration of action. Here I would add the 0 adverse events which we see of cataract, raised IOP, inflammation with brolucizumab or biosimilars, and contamination with bevacizumab and the Indian steroid formulations. And it has gradually become the first line drug in treatment naive patients, as everybody was saying here, because of its best response in shortest time. And we know that early anatomic improvement will give the best visual outcome long term, because it prevents damage to the retinal cells, drill, etc. And the long duration of effect reduces the treatment burden also, which is not only cost but also the risk of infection and endophthalmitis. So this patient is to demonstrate how a treatment naive patient will behave. We injected him in January, and in March, you see 2 months later, the vision has improved significantly, as well as the anatomy. We did inject at this time, and you can see that 14 months later is where he had a recurrence. He continued to improve, had very good reading vision of N8, and then only at 14 months after the last injection, he came back with a recurrence. So that's the duration of effect with the aflibercept. And the visual results are often superior to the anatomic results. Now, this is a patient who had ranibizumab earlier somewhere when he came to us. So we started with aflibercept in 2019. So with one injection, you see the marked improvement in his vision. And this was bilateral case, so he was very happy. We re-injected him at 3 months, and then again at 3 months. And then you can see that there was a marked anatomical improvement as well as structural. At 9 months also, his vision was so good, 9 months after the last injection, that he refused to take an injection. Though we said that the edema had recurred, he refused to take it. He agreed only after 12 months of the last injection, because there was a slight drop in vision. And after this injection, even the anatomy was good at 6 months. And he came back only after 10 months agreeing to take an injection. So 10 to 12 months was our duration of effect. Long treatment intervals. Visual results are superior to anatomic results. And near vision or reading vision improves much more than the distance vision, which most of our patients really need if they are working. This patient is to show a DME which this is usually what we see, which does not respond to anything else that we have at this time. So this is a patient in 2017. For 1 year, 1.5 year, we treated him with IVTA because of financial constraints every 3 months. And there was some response. So 1.5 months of IVTA. They stopped responding to IVTA, so we treated him every month with IVTA. But even with every month, we were not getting a response now. So we spent 1 year in that. Then we shifted, he agreed to take a DEX implant, and this showed no result. Even at 2 weeks, you can see the response. So we tried two DEX implants, that didn't work. So finally, he agreed for aflibercept, and at that time, the ILIA4U program was there. And you see the immediate reduction in the thickness and visual improvement, which lasted for 3 to 5 months. So after that, for the last 2.5 years, he required injections every 4 to 5 months. And since October of last year, he has not required any injection. When he came last few days back, there was no edema with good vision. So response was superior to steroid implant, lasted long, and earlier switch could have given him a better visual acuity. And that's how we have shifted it to our first line treatment rather than as a last line. Now, very important, which I have been working on recently, is how hard exudates respond to drugs, any drugs. And this is a lady with hard exudates. You can see how she improved within 2 months. The hard exudates have resolved, but she could not come for treatment because she developed COVID infection. And when she came back, you see how much of exudates have increased. But again, we repeated twice at 2 month intervals, and you can see a marked resolution of hard exudates. So aflibercept is effective in the treatment of exudates if it is given properly in 2 to 2.5 months. Steroid is not a default therapy for hard exudates. Resolution happens fast, but long treatment intervals will allow progression of exudates. So this is another patient, bilateral. You can see 2 injections given at 3 month intervals, and at the 6th month, you can see the marked resolution, at which time we did laser. Another patient, we injected just one injection in December, and by February, you can see both eyes, the hard exudates have gone in each eye. This is to show when a patient doesn't take the injection, then you can see the increase. Here you don't see well because they are fine exudates, but at 6th month, because the patient did not take an injection, the increase in exudates, he was so comfortable with his one injection that he refused to take at the 2nd and 3rd month. And finally, the effect of aflibercept in a vitrectomized eye, which does not change in a vitrectomized eye, just like a steroid. So here you see in January, we gave an injection, and the patient was very good and came back only more than 2.5 months later, which is its usual duration of effect compared to a DEX implant. Thank you.
Thank you, Dr. Malika, for showing excellent cases. You have given real food for thought for everyone, and how we can, we'll have discussion later. I think I call upon, because since this is a real world experience on DME, I call upon Dr. Bhuvan Chanana for his talk and share his experience with real world cases.
So very good afternoon to all of you. I'd like to thank AIOS and Bayer for inviting me to this session. And I think we have discussed all the important points regarding the use of anti-VEGF in DME. So probably my real world experience will just say the same thing. So I'll be presenting a series of 4 to 5 cases, 4 to 5 different cases, and how they responded. So the first case would be was a 50. It was an old case, 50-year-old male around 2018 when aflibercept was just introduced. His vision was 3/60. The patient received two ranibizumab injections. However, the vision did not improve, and there was no reduction in the macular edema. The patient was then lost to follow-up for about 3 months and did not have any improvement in the vision, neither in the macular edema and OCT. That was the time when I first used aflibercept. This is one of my first cases, and after 2 injections, the vision improved to 6/18, which was sustained with treatment on aflibercept. The vision improved to 6/12, and the OCT also gradually improved. So after that, I became more confident in using aflibercept, and I started using them in treatment naive. This was 2019. They also came up with the reduction of the cost. So this is a treatment naive case, and we all have seen that there is presence of diabetic macular edema. After 2 aflibercept injections, the vision improved to 6/18. So again, I maintained this patient on aflibercept PRN regime, and the vision improved to 6/9 after 3 aflibercept, and after 5 aflibercept, the vision was retained. So now coming to case 3, this is a case of drill. There is some intraretinal cyst, there is disorganization of the inner retinal layers. So there is some macular edema is also there, but the inner retina could be seen. So I gave aflibercept, the vision improved to 6/18. After 3 aflibercept, the vision further improved, and the foveal contour also became much more normal. So this is the same treatment on a treat and extend regime. After 7 aflibercept, the foveal contour has remained better. Somehow, I don't know, initially which I thought of drill was probably not drill, but also that also showed there was more clarity now in the retinal layers. So drill usually should not improve. So probably it was not drill, or probably some mild improvement in the drill. So this is another case in which there was presence of a chronic diabetic macular edema. After 3 aflibercept, there was no improvement. The vision improved by 6/60, and at this time, since there was no improvement, I decided to give him a steroid implant, and after 4 weeks, the vision improved, and the macular edema also resolved completely. There was a recurrence of the macular edema after 4 months, and a second Ozurdex implant was planned, and now the patient is stable at a vision of 6/18, and after 12 months. So now coming to my last case, this was also a non-responding case. After giving 3 aflibercept, the vision did not improve. So again, I decided to give a steroid implant, but this patient denied. Since the patient was in the patient support program, he said, I want to receive my rest of the injections. And after giving 5 aflibercepts, the macular edema resolved on its own. So probably this was a slow responder. I would like to really know how to differentiate a non-responder from a slow responder, because I think most of us make our switch after about 3 injections, or probably even after 2 injections, which have been, people make it early now. So the patient is stable and is on a extend and observe regime, and after 9 aflibercepts, the vision is pretty stable at 6/12. So just thought before giving anti-VEGFs endlessly, we should look at the anatomy, presence of any hard exudates, increase in the presence of macular ischemia with increase in the FAZ. So these are the cases which will not improve. This was one case in which has received probably 12 or 20 of anti-VEGF, but the vision is not improving. So this is an octa showing an increase in the FAZ. So this is just the take-home message. I think the most important thing is the control of the systemic status, which has been highlighted. A regular checkup should be encouraged. Good counseling should be done. Control of the hypertension, anemia, diabetes status of other comorbidities is very important. And according to protocol T, I think aflibercept has been proven to be one of the most superior anti-VEGF agents in vision less than 6/12, and in vision if it is better than 6/12, then probably it results in faster resolution and lesser number of injection, which has also been highlighted in the previous presentations. So intensive treatment is the key for the management of diabetic macular edema. I think in the initial period, that will not only reduce the further injections, but will also reduce the overall treatment burden on the patient. And it is important to rule out the anatomical alterations, presence of hard exudates, macular ischemia, to counsel the patient beforehand. So thank you all for your kind attention.
Yeah, thank you, Dr. Bhuvan Chanana, for the nice cases, and also Dr. Mallika Goel shared some very nice cases which were resistant to earlier treatments of whatever agent they were giving. So it boils down to, the same questions repeatedly probably we hear, but is there any new insight which our panelists can give today? Ashish is raising his hand over there. So, Ashish, if I can ask a question, then you can also give your comment, maybe related to my question. Yeah. So, the question is, do you still use ranibizumab, or you always start off with aflibercept? And if you use ranibizumab, I'm not saying biosimilar or innovator here, when do you switch to aflibercept or any other agent, Ashish? Yeah, so do you use ranibizumab?
No.
And
Yeah, primary therapy because of the financial reason. Otherwise, I would start with 50%.
okay, and when do you look to switch in terms of how many injections, or what OCT criteria parameters would you look at?
Means with every injection, I should see a response. The
Okay.
point I should know, I'm not seeing the response, that is my change.
Is
I
it
should
after
see
one
some
injection
response.
you don't
Even-
see a
yeah.
response?
Yes, even after one injection, if I should see a response with my therapy, even
Very
with one
good.
injection.
That's something, I would say not new, but at least something different. Dr. Mahesh, how many are you? The first question is: are you still using ranibizumab, or if yes, when do you look to switch?
I am using ranibizumab for the same reason like what Dr. Ashish mentioned. So if when I would switch is probably 3 to 5 injections later, but I would, like Ashish mentioned, I would look for some change in the edema, with particularly a naive patient. Some change in the edema, I would continue. Frequency of injection increases, or if it stops responding and the vision has not improved, is when I would switch.
So even if after one injection you don't see any improvement, you are willing to switch?
No,
Is that what?
I will not.
You will not switch.
Like probably 2 to 3 injections is when I would. If there is absolutely no change, is not when we switch.
So, Dr. Hemant, in terms of switching, like we just now discussed about ranibizumab to aflibercept, but that may not be the necessary sequence anyone uses. So, if let's say you have used ranibizumab in a patient, uh, do you ever consider switching to, let's say, maybe dex implant or brolucizumab without considering aflibercept, or do you necessarily go stepwise, aflibercept, or is it dex implant and then looking for the next agent?
No, when I see that there is no response to anti-VEGF, especially let's say the patient is pseudophakic, so I also look into the other factors.
Can you
And-
specify the anti-VEGF you're talking in this
Let's say
particular?
we start with the ranibizumab.
Okay.
Let's say that's what primarily is used because of cost reasons. Now, if they fail to respond to that because it's in the same group of drugs, and I feel that it's a pseudophakic, I would try to put in a steroid implant in that situation. But if it is phakic, I would change over, switch to an Eylea or something like that, aflibercept as a switching drug, provided I see no change. But
So
I
that-
would probably look into other factors before I really say whether I continue with another anti-VEGF or with a steroid.
So basically, you're looking at the lens status basically to decide on the other choice
And
other
the
than
glaucoma, if the patient has a large cup or has some changes in IOP or borderline IOP, I would probably not use steroid as the switching drug, probably change to aflibercept.
So, so George, I would like to give one information from a study we are doing at LVP right now, and then I'll follow up with a question. So, we have looked at 50,000 patients who have received anti-VEGF injections, but not DME alone. It's a whole broad basket of indications. What we found out that patients who pay out of pocket, self-pay patients, have 42% compliance rate for the first injection advice. They come for the first time. Insurance patients 100% compliance for the first time that they come. But then among the patients who come for the second visit, a lot of dropouts happen between the first and second visit. But those who do come for the second visit, the compliance, if I advise another injection second time, it is 80%. So 42% the first time. The second time it improves to 80% among those who come. A lot of dropout between the first and second. But do you consider this durability at what stage do you start looking at the prolonged duration of action? Because anti-VEGF usually you have to give monthly in the first. So at what stage do you start looking at this durability of action, given that now brolucizumab and now faricimab is also going to come? At what stage do you start looking at it?
No, this is only after the initial good response. What you're saying, after the second visit, they become more compliant. That's because that's a time when the vision starts improving. See, after the first injection, we already discussed about when to switch. So the consensus from academy says 3 to 4 monthly injections and at least 50% of the excess thickness reduction. That is one of the guideline which you asked. So even she showed a beautiful case of late responder, wherein after the third after the third injection started responding beautifully well. So the late responders are there. So that is why after the first injection, if you take a call on switching to steroids or brolucizumab or what, that may be we are looking at something like that's what I wanted to add to the first question. Maybe it's a late responder. To what you said, the after the second injection, the compliance increases because that's the time. If you look at the peak of vision improvement happens after the first couple of injections. Then you look at like DRCR protocol, whether the vision has maximized. I look at whether vision has maximized or not. After the first 2 injections, vision had improved from 618 to 612. Almost dry macula. I go ahead with the third injection. Maybe it will reach 6.9 or 6.6 parts. Then we look at the longevity of that. So once you have reached the peak of vision is the criteria, and then not the drying of macula. Vision is the criteria. Then we look at reducing the injection. DRCR protocol says stop it and wait for the recurrence once you have reached the visual acuity maximization. But then I do probably look at one after 2 or 3 months, follow it up with an injection and slowly stop it off.
So, sir, I have a question for you. So since you said 42% for the second injection, the compliance
first injection is only 42% compliance.
There is a dropout of 42%.
No. So if 100 patients come, first time I am advising anti-VEGF, only 42 take injection.
Only 40.
Self-pay. If it's an insured patient, 100, all of them take.
So
this is despite the patient
consideration.
This is despite the patient support program.
This is not about ILR. This is all across self-pay patients.
Okay. Because what I observed is just because of this patient support program, many of my patients the compliance has increased because they know that okay, the next injection I just highlighting.
Yeah, the second and third.
So
they ask for it.
They ask for it.
They ask for it.
So
second,
I think
third,
this is something probably with which we can increase the compliance.
Correct.
But different, not even I think now every anti-VEGF is trying to come with a patient support program. I think these are
but there is a big
needed.
gap. There's a gap between whether if the patient has first thing, the patient has to come back to you. That's a big dropout there which is happening, and that I'm not mentioning here. But what Dr. George has pointed out from his beautifully answered is that we need to be a little bit aggressive in the first 6 months. You can't delay the treatment that okay, I will let it linger on and then later on we will see if further improvement is required.
Just want to add to the PRN is the maximum dropout happening because you wait for the recurrence of the edema and then patient gets think that he had a slight improvement after the first injection if you're starting PRN from the beginning, like what you are asking first. So then patient has a recurrence, there's a high chance of you losing the patient and the compliance.
Basically, I think you have shown a case as well as Malika, the real world experience. I think there was a gradual improvement in visual acuity and the injection went up to 5. And you have shown after that it remained stable and the vision remained good. I think that is the way, if we look at it, that it is not only 3, we talk always 3, but many of our cases, if they are improving vision and getting better, I think because patients, like just now, Dr. Lalit is talking that after third injection, 2 are free, patient is willing to take that. I'm talking of once somebody is receiving Eylea. But this I have also myself observed in recent time, not only their vision remain better, their requirement for injection subsequently goes down. I think that is what patient is looking, what we were talking, as far as the durability is concerned, because that is what we are looking, all of us, at that.
Rajay, even if you consider cost, you see, our usage of ILIA has shot up after this program came in. When it was 68,000 rupees, you see, cost the total number of anti-VEGFs in diabetic macular edema is was predominantly ranibizumab. Now the usage of ranibizumab in DME has decreased to 5% now, and 85-90% is aflibercept. Although data from protocol T and other things are also there, but and from the economics point of view also, you see, it is economical now. The cost is
Very
comparable or maybe better also. Plus the longevity compared to ranibizumab, with aflibercept you expect at least 2 or 3 weeks longer duration of action. Plus, if you, what George was saying, if you hit hard in the beginning, what Mangat was saying, if you hit hard in the beginning, then the requirement does come down.
Yeah, so we should not be carried away. We should be clear that recurrences do happen. That's not the same as resistance. So if you have a patient who improves and then it comes back, it is part of the natural disease cycle. So we should not be worried about a durable drug or longevity initially. Whenever there is edema, you have to treat it aggressively. Once you achieve the maximal visual gain, then you can look at the durability.
The concept of 3 injections is more for I think PCV or CNE. For diabetes, we have to do a early intensive treatment for better outcomes, as said.
Yeah, Ramesh and maybe Ashish, I don't know, you had some other point to, but you can, yeah.
I might create controversy here. So what is happening
Welcome.
is, so as you first question was, did you have any other insights? So the question boiled down that what is the best vision achieved? That is a question that we always ask. DRC has proved anything which is 20/25 or better, in spite of, irrespective of whatever IRF you see, you don't treat it. We accepted it. All the protocols of DRCR in other, even the means all the trials where even monthly injections were given, at the end 30 to 60% patient had IRF. So what we have looked over the time when we published, that these are two different diseases, AMD and DA. So our fluid analysis has to be different. Our tolerance towards IRF should be different in this. So what we published in 2019, based on my experience, single center experience, we gave a protocol called snuff orb. This was in a subgroup of patients who present to you with subfoveal neurosensory detachment. So what we saw from my practice, we gave a concept that, these kind of patients, once you treat them and as soon as the neurosensory detachment flattens and what visual acuity you achieve at that point, then you keep treating those patients forever. Visual acuity does not change. So whether can we tolerate that IRF after, so probably here when the photoreceptor detachment happens and then attachment happens, your limit of achieving 2032 or 2020 goes slightly down. That concept we gave, but we were not sure, how that would fit in terms of visual acuity. Now we have the data of 188 eyes from SNEC, from Milan, from my center. So 6 centers together. Means we have just submitted the manuscript, so I'm just disclosing that what we found. All these patients who present with SNUF, means subfoveal neurosensory detachment, if they achieve 20/50 or better, you don't treat them irrespective of IRF. Tolerate it the way you tolerate in a normal patient with 20/25 or better. If anything goes down below 20/50, then you treat them till they reach 20/50 or better. Means we are just trying to give another way of,
What is so simple?
So another way of giving a little more of, better financial economics to treat these patients. It will attract a lot of controversies in terms, means we are just still waiting for the review, but that's what, we have seen. So this is another way to look at it.
No, so if you look at all the DRCR protocols, it's in the first 6 months that they have said that don't tolerate any fluid, and you only stop if you achieve 20/20. But after that, it's like the same protocol which you're saying. If the edema is stable and there is no 5-letter drop or more of vision, you can avoid re-injections. So once you achieve the maximum visual acuity and the edema is stable beyond 6 months, you don't have to re-inject just because there is edema. And that's what DRCR protocol, at least the later protocol, started doing that. And that's what I would say is, we as DME versus AMD have to differentiate. In AMD, it's not about visual acuity anywhere, it's about any fluid. Whereas in DME, after the first 6 months, if the edema is increasing, you still have to treat those patients.
Yeah, so we are looking at this subset of patients, which consists of approximately 40% cases of your practice. So it means whether ultimately the question boils down, what is the best visual acuity you achieve?
I think the difference between what you are saying and what he's saying is, DRCI protocol is after 6 months, irrespective of vision becomes the criteria, whatever maximum. I think here there's no time limit about.
No, he also would have a time limit. You can't expect at 1 month to gain 20/50.
No, if I go down in terms of my visual acuity, whether NSD is there or not
after what time or number of injections? Because at first month,
is there a time or injections?
Second month,
our main primary focus here is visual acuity. I do not believe on IRF in DME.
So actually, let me put it again here.
Okay.
So a patient of 20/80 achieves 20/50 at 1 month.
Right.
So will you
has some SRF. Okay. Now, what are you going to do? Are you going to re-inject, or are you going to say, I will tolerate SRF? What basis?
So I will tolerate SRF there. I mean IRF. I am tolerating IRF there.
So you won't go for 20/40.
I won't go for that.
How do you know patient is not going to achieve 20/40 or even 20/20?
That's where we are going to attract a lot of criticism. That's what I am saying.
So first you need to give 6 months at least for that.
No, what happened? When we have compiled this entire data, that was a striking finding that the potential for these patients after this flattens.
Ashish, there is a possibility that this patient may improve from 20/50 to 20/40 also.
Or even 20/20.
I agree, sir. I'm not denying that.
Yeah.
So you can't decide at one injection.
What is so sacrosanct about 20/50?
Yeah, these were the criticisms will come.
What is so sacrosanct about 20/50?
So that's what the data says. We talk about the data. That's what the data says. Out of this entire
Ashish,
cohort of 188.
Dr. Ashish, you treated these patients monthly in this trial, correct?
No, sir, he says even with one injection.
Irrespective of protocol.
No. In the existing protocol, you treated these patients monthly.
No, sir. This was not a defined protocol on a prospective basis. So this is basically retrospective data from the multiple sites.
These patients were not treated continuously.
Means they were treated the way that site wanted. For example, in India, we would treat it in a different way. Ultimately, our aim was that what visual acuity was there when they achieved first flattening, and what visual acuity was there when their outcome was at the end of 2 years.
No, but if you're treating
I personally don't think so that we can accept this, or we can advocate this at 20/50 one injection.
One injection you can't max out.
You can't because maximization may still occur.
Yeah.
You see, if after maximization, then it's okay. Then it's digestible at least.
That has come from
That is
prospective studies.
I might create a controversy.
No,
That's what I did.
From prospective studies. But thanks for bringing up the controversy, basically.
No, retro data analysis may be something different. If prospectively something is done, that's totally.
Yeah, so we came up with concept in 2019. It was published in Ophthalmology Retina, and editor-in-chief said, yes, you publish it. I see a value. Then he said, prove it. Then now we are at the second stage where there's a multi-centric data. Next would be prospective. What we are expecting, I have written an email to Neil Bressler that please analyze this subgroup in a different way. This is only patients with NSD, that what they achieved. Analyze that subgroup in your protocols of DRCR and see whether we reached to that conclusion.
Thank you, Ashish. I think here we'll keep on, and I think we move on to the next talk here, and it's going to be on AMD, neovascular AMD, and Dr. Vinay Gorodia. He's going to give a talk on is extension and maintenance of 4 months treatment interval possible in neovascular AMD. Dr. Giridhar, please come over here. You'll have to ask questions from here. So you come. You have to come.
Thank you, sir, and good afternoon, friends. So after a very interesting discussion on DME, I think now we are going on to the next where anti-VEGFs are used maximum. In fact, that's where the anti-VEGFs came in for, and now we have expanded the usage to DMEs also. So we'll be talking about how we can treat treat AMDs better, and how we can do the treat and extend protocol, and how best we can follow that. So very important parts in any treatment is prompt diagnosis and initiation of treatment. And second point is most important, that you have to educate your patients what you're going in for. So something like what Dr. Raja was saying, that first time the conversion was about 42% for them. But if you have convinced them well about the need of multiple injections, the second time conversion is going to be 82%. That is not a surprise. So if you counsel them well, your compliance for the future injections is going to be better. So it's very, very important to educate and discuss with the patient right at the beginning that they'll be needing more injections than one injection. And initial treatment has to be done till the lesion becomes inactive. And after that, we have to try to decide what strategy to follow. So there can be options of either we go for a PRN, we go for a fixed dosing, or the topic of discussion today, the treat and extend. So what we have found from the studies is that after the initial inactivation, there's about 40% patients have a recurrence that happens within 1 year, and about 80% of them would recur within 5 years. So we have to decide about the long-term strategies. But one thing to note out here is that there are still 20% of the patients who would still not have a recurrence happening. So probably that is a subset that we are going to be over-treating by doing our treat and extend protocol. So we have to have some ways, hopefully in the future, to try to find out which are the patients not likely to recur in the future, and they can be separated and spared the treatment. So that's one thing we can, that's something for the future we have to look at, right? So the basic therapy for continuing, there are two options. One is after we do a fixed Q8 dosing as advised by AIOC people, or we go for a proactive treat and extend dosing. So the goal should be to maximize the visual outcomes with the minimum burden. So we cannot keep doing every 2 months to a patient who possibly doesn't require it. So we have to maintain the good vision without causing any, minimizing the burden. One thing is important for treat and extend is whenever the patient loses vision or whenever the edema comes back, he loses some vision whenever you treat them again. So PRN therefore is not a very, very attractive strategy. And as someone said, the chances of dropouts on PRN are much more. So we should try to minimize the recurrences in the best possible way. So the basic principles are that we have to titrate the treatment intervals for each patient, because every patient, every eye, and the stage of the disease demands different timings. So at some stage, it may be requiring every 2 months injection, but some stage might be okay with 4 monthly. So your titration has to happen, and it has to be more dynamic. You should be ready to change. And every time the patient comes to you, he gets an injection, and the test done on that day determine when he's going to be called next. So that has to be explained to the patient. So patient comes for the injection, he is investigated that day, the visual acuity, OCT, and everything is done, and that determines whether he's going to be called at what interval the next visit. So let's talk about Altair, which compared the two options of adjusting the treatment intervals by 2 weekly interval vis-a-vis 4 weekly interval. So they were randomized into the two groups. And so this is basically the graphical representation. So after fourth injection, they were randomized into every 2 weeks adjustments of increasing, decreasing, or maintaining the duration vis-a-vis 4 weeks intervals. So the criteria were very simple. So if the patient was stable without any fluid, then we extended the interval by 2 or 4 weeks, depending on which arm you were there. If the patient was responding, but still the fluid was there, then we maintained the same dosage. And if the patient was worsening, when the fluid was increasing or new fluid or decrease in vision or hemorrhages coming in, then we decreased the interval. So with this, we found that both these strategies work pretty fine to maintain the visual acuity in the long term. And it was also found that about 60% of the patients could be maintained at Q12 intervals at the end of 2 years, and about 40% of them could be maintained at Q16 as well. So that was quite exciting, and both the groups could maintain the vision well. But what was also found that if you're doing a 4 weekly adjustment, the chances of patients going back was more. So there were about 77% of patients could be maintained at the same, whereas if you're doing at a 2 weekly more conservative kind of an adjustment, about 96% of the patients could be maintained there. So I personally follow a 2 weekly adjustment rather than 4 weekly, because that's like there's a lot of fluctuation that is happening in the whole thing. So I don't like that. Now coming to brolucizumab, they also came out with the Hawk and Harrier study, and they found that about 50% plus patients at the end of 1 year could get a Q12 interval. That was quite nice. But the problem happens when you extend it further to 2 years, then you realize a lot of them were dropping to less than Q12. So there was only about 40% of patients could be maintained at Q12 interval at the end of 2 years. Now that is possibly because, as we'll be explaining later, that the half-life of brolucizumab is lesser than that of Eylea, and the molar dose is more. So maybe initial first year, because they are giving the loading doses a very high molar dosage, therefore initial year they can maintain at Q12 better. But as that initial concentrated medication effect goes down, as they go to the second year, their Q12 is also not being achieved in more than 40% of 60% of cases. So that's something of a concern. So the same thing you can see compared to Eylea, you can see that the patients who achieved a Q12 or Q16 were maintained at that. Rather, the percentage of people maintained at that rather improved over a period of time, as we would expect it to be, because as the disease is becoming less active, we expect more and more people to be maintained at a lesser frequency dosages. Whereas in case of brolucizumab, it was the other way around, so that is something of a concern. And we have got some initial data from faricimab, which suggests that these patients do even better with a 3-monthly or a 4-monthly interval. But the data is very new. The criteria that were taken was very different. There was very rigid kind of a thing. They were not flexible about changing the criteria. So these are early days ahead right now. So coming to the real world evidence, the real world evidence has shown that treat and extend works quite well. And there are multiple studies which have shown. So in this particular, you can see that over the 4th year, the number of injections had gone down to about 2 to 3. So there are multiple studies which have shown that these injections work. And as the year goes by, the number of injections per year go down. So to summarize, then we have got this ALTAIR and ARIS that we have. But we also have data saying that, for example, in the study, we see that as in MoveField study, you can see the first year they got 7.4 injections, second year was 4.9, 4.2, even goes down to about 3 injections. So more and more patients, and about 50 to 60% of patients are maintained at Q12 or better. So that's interesting. Now coming to the last part about why we have got so many options, and I think though this is a Bayer-sponsored symposium, so of course everyone feels that Bayer aflibercept is better. But if you really do analyze it, you do find that as of today, what we have, this seems to be the better molecule. Now, what is important is the binding affinity, the elimination half-life, potency, clinical targets, and the molar dose. Now, these are important when you talk about the efficacy and the durability of the action. So coming to binding affinity, we know that the aflibercept has got a very, very high binding affinity to VEGF compared to the competitors ranibizumab and brolucizumab even. So it's about 10 times more affinity than brolucizumab, and much more than 100 times more than ranibizumab. Faricimab, we don't have so much of data, but it seems to be similar to ranibizumab, so it's also going to be low for this. The second is the half-life. So when you look at the half-life, again, aflibercept does better compared to ranibizumab, and brolucizumab, surprisingly, which was supposed to be Q12 interval, has got the least of the half-life. That is because of the smaller molecular weight of that molecule compared to the others. So again, coming to the potency also, potency is the concentration of the drug required to have the effect in the number of moles point. There again, we see aflibercept scores over the other options available with us. And the other option now is that what if we combine other pathways also along with VEGF? So like brolucizumab and ranibizumab work only against VEGF, whereas aflibercept has an additional later derived growth factor also, which possibly gives them some benefit in the DME cases. And the newer one that is coming in, faricimab, has got angiotensin 2 arm as well. So we still don't know how effective is that going to be, but that's what we have to watch at, that along with anti-VEGF with angiotensin 2, whether it will be more effective or not. But again, that was, as was shown earlier, that if there's a low VEGF levels, then probably angiotensin 2 doesn't play that much of a role there. So, but those are all theories. We have to actually get our own real world data before we decide if faricimab is going to be any better than aflibercept that we have. And the last part is the molar dosage. Now, if you see the equivalent molar dose of aflibercept, if you compare that with the other, so we give 2 milligram of aflibercept vis-a-vis 6 milligram of brolucizumab. So we are, as it is, giving 3 times the dose when it comes to weight. And then on top of it, when the molecular weight of that compound is lower, so number of moles that you are putting in is about 10 times, more than 10 times. So you're basically putting many molecules inside the eye. And that is possibly the reason why we are having better effect in those cases which are not responding to aflibercept. They respond to brolucizumab. But does it come with a price, at a cost? There is a more side effects that we know that happens with it. So maybe that is the reason for it. But I would rather be happy with aflibercept, which gets the same effect at 1/10 of the number of molecules inside the eye compared to something which we are using more than 10 times the molecules inside the eye. So this again, you see that these are the graphs that you can see that the effectivity level. So the half-life inside the eye, the effectivity, the data has been projected to be 36 days for ranibizumab, 52 for brolucizumab, and 71 days for aflibercept. So there's a benefit of about 19 days over and above brolucizumab that is there. So to sum it, I mean, how do I personally do the treat and extend? And I would like the opinion of the house to see if there can be any changes. So for me, aflibercept is the first choice for AMD. I reserve brolucizumab for refractory cases only. I don't use it as the first choice. But one caveat I would like to tell that if you use brolucizumab, do not call the patient after 3 months, the way we do for Eylea or other cases, because these patients may, though a very small person, may have an inflammation happening. And if you don't catch it at the right time, the courts are not going to listen to you that you didn't call the patient on the right time. So you have to still maintain a very close follow-up if you're using brolucizumab. So that is very important. So it may not be a real treat and extend. You have to keep checking them every few weeks to see that how they are doing. I do discuss the treatment plans with the patient attendants. I don't go with 3 loading dosages. I go with inject monthly till I get the response. And then I plan to extend from there. And once stable, then I would adjust Q 2 weeks rather than 4 weeks. And if I have a patient who's at a Q16, I somehow feel more comfortable calling him at 2 months for a checkup rather than calling him straight after 4 months. Of course, if the patient is from outstation, I would call him after 4 months. But a local patient, I would prefer to see him after 2 months. And of course, SOS is always there with him. And as I said earlier, there's always a 20% of the patients who probably won't require any injections at all. So when we talk about 40% patients are switched to Q16, actually 20% of those are benefiting from you, and 20% were anyway not going to be needing even that Q16. So we have to think about whether we can extend that from Q16 to Q20 or Q24 also. That's something for the future that we have to work on. Thank you.
What I mean, before we, nice presentation, sir. Before we start the discussion, what do you mean by once? Can you show the last slide, please? That is, once it is you have finished the loading dose. What is that? One stable at just Q 2 weeks and not Q 4 weeks. What do you mean by that?
So that's the Altair study. That in Altair they basically increased or decreased the duration by 4 weeks vis-a-vis 2 weeks. So I prefer 2 weekly adjustments.
That is when you start the TNE, right?
Yeah, for TNE. Yes.
Is every 2.
Yeah. So like if the patient is coming at 8 weeks and he's stable, I'll make it 10 rather than 12.
Okay. So we'll start the discussion again, like the DME. So I just written down a few questions. We'll start with the panelists. Number one is, what is your first choice of drug for in wet AMD? Does it depend on the morphology? If the patient can afford anything, let us forget the affordability. The patient can afford anything. Mahesh, what is your first choice? Is it aflibercept or is it?
Now it's aflibercept actually.
Pardon?
It's aflibercept.
Aflibercept.
Whatever type of wet AMD, it's aflibercept.
It's aflibercept. Okay, thank you. Hemant, any difference of opinion or same?
Same.
Okay, anyone having a different opinion? No. Okay, great. So Bayer is very happy. So second question. Loading dose. Now, Mahesh, do you give a loading dose of 3 injections initially, or you have a different protocol if you're giving aflibercept?
Sometimes there's a slight difference in the protocol. After the second injection, if it is completely dry, I may start the loading dose then itself. Instead of giving the 3rd injection at the next month, I'll probably call him 6 weeks later.
Okay. Hemant, any difference of opinion?
I think you meant you start treat and extend. Yeah. So I would follow a very similar, but not less than 2, and 2 would be the minimum. And then look
You're talking about TND.
Yeah, then I start treat and extend.
Okay.
No, when you say the loading dose.
So coming to treat and extend, that means in all patients with wet AMD, after the initial loading dose, you immediately start TND.
Yes. He's saying loading dose maybe 2 also.
2 also.
That is
2
what
injection also.
Yeah, that's what. Loading dose is 2. Maybe 2. If it is dry. If it is dry, you stop at 2 and then you follow up.
Complete visual improvement.
Okay.
That's what.
Okay. Okay.
But sir,
You see,
sir,
that is not so common. You see,
Correct,
prednisone is
correct.
not
So
so
it's
common.
not so.
It happens.
We
but,
analyzed our data,
yeah.
and majority, we looked at what was the minimum number of injections AMD patients had. They were about 2.2 or 2.5 is what is the average. So I know majority did receive 3, not less than that. But everyone received 2 at least.
Yeah.
So that's
I
like,
mean, yeah.
sir, if the patient is still not dry and
No,
you feel
that's-
there's a potential for improvement after 3, when would you give the 4th injection? After 4 weeks or after 8 weeks?
No,
Continue at 4 weeks.
Doc, we'll come to that.
Sorry.
We'll come to that.
Sorry.
See,
sorry.
what they are saying is they are looking at dry. I mean, that is once the macula is dry, IRF is not there and SMD is not there. After in ILIA you have the scheme, so 1+1. So the second injection is free. So he says he'll give the 2, and at that moment of time, if it is completely dry, he will not give the third in probably immediately. He will, he may delay it a little. That's what he said.
TNE started. TNE started
Yeah.
earlier.
Okay,
earlier.
that's coming later. My question was, if it is still not dry,
Yeah,
would you
it's
go
not-
for Q8 after that, or would
No,
you
no,
still continue with
it's
Q4?
not
That question has no validity now,
no,
because the
Yeah.
condition has become dry.
Yeah.
Huh.
So any difference of opinion? I mean, it's all the same, right? Okay. Now, next question. Hey, Mahesh, do you treat all your patients with wet AMD on a TND basis, or do you have any other? I mean, that is, once the macula is dry, say you give 2 or 3 injections, it's totally dry. Now you straight away go into a TND, or do you practice PRN?
It can be a treat and observe. It's not a PRN. So if it's absolutely dry, then I'll probably prolong it by another month or 2 weeks and see how that particular patient behaves. So if he's going to recur it in that 1 month, then I alter it a little bit. So it's not that if it's absolutely dry, I inject and follow. So at that point in time, there's a little modification of treat and observe can also be.
So what you meant is that you will look into the behavior of the disease during the next 2 or 3 months to see how frequently they need the injections, and based on that, you take a call, right? Hemant, do you agree with Hemant? I mean, Mahesh.
I would also do very similarly on that.
Great.
The only thing is like this, that I also discuss this with the patient. A lot of them feel that they would like to do the PRN, which I then leave it to the patient's option.
Okay.
If
fine.
they're agreeable and they understand the concept of treat and extend only.
Okay. And in all this, I mean, do you have a difference if it is a type 1 or a type 2 or a type 3? Because a type 1 is always quite safe, whereas a type 2 and a type 3 are more aggressive. So do you have a different protocol when it comes to the type of wet AMD that we are dealing with? I mean, I felt that that's quite an important issue. So is there any difference of opinion as far
Type
as
2 generally they do require more number of injections. And
so you would like to follow up the type 2 and the type 3 more frequently than probably a type 1, right? Type 1, you may probably, once it is dry, you may call them after 2 months or something like that, because you know they may just come back with a mild SMD. Whereas a type 2 or type 3, you may like to follow up more sincerely and inject. Okay. Anything else, George and Ashish?
Yeah. To the question which you asked after the loading dose, I generally stick with 3 injections unless it has maximized the vision with 2 injections, like what Dr. Mahesh was saying. But then if the patient is outstation patient, stick with treat and extend, because if you are thinking of you need monthly follow-ups to see what's happening.
Yeah.
So if it's an outstation patient, strictly on treat and extend, and treat, extend, and stop. That's what I practice.
Outstation and very elderly patients.
Elderly people with multiple comorbidities, stick to the treat and extend and stop the regime. There is a regime called treat, extend, and stop. So just treat and extend all the injections at once it reaches once in 3 months injections. Then stop the injections and see, because the drug doesn't last more than 3 months usually in the eye. Stop and see. But then if you are stopping and seeing, after stopping, follow the patient 1 monthly.
Patient will come back with
After, I mean, if it is dry macula after the last injection.
George, a lot of these patients will come with a hemorrhage actually.
Yeah, not that you are not losing the follow-up.
Patient will not come. Unless you scare the patient, he will not come.
So ideally, if you are doing a treat and extend, for 2 years, he should be on once in 3 months injection. Invariably, if the patient is having edema or not. But then that is not practical. So like after you reach couple of injections once in 3 months, Stop and see monthly follow-up and see whether activity is there. Then you can extend only on follow-up once in 3 months. That's what you follow.
Giri, I don't like to discuss too much with the patient, because experience has taught that in case, say, we observe after 3 months, a lot of these patients, I do not have numbers, will come with some macular hemorrhage after some time. And then the scenario may not recover completely. So in AMD specifically, after it has maximized, then all of them patients, irrespective, I will at least scare them that you have to have this injection after some interval or so, which we have found out it is best is around, say, 10 weeks or 12 weeks. But they have to have that.
Once in 3 months. For how long?
We continue. Actually,
You see, I personally would not say, okay, disease is over and you stop it now.
No, I think Lalit, see, once we
Unless,
give this TNE once in 2 months or 3 months,
Yeah.
and in about 3-4 visits, when
Yeah,
we do
if
the
3-4
OCT, the
visits-
macula is totally dry.
That means 1 year. That means 1 year, approximately a year.
No, what I'm saying is, if the macula is totally dry, I think, I mean, at least I would like to just see, extend it a little more and
Little
see
more,
whether
yes.
we can, delay the injections even further.
But I agree, the word stop, it does not come.
Yeah,
so I
stop
will-
doesn't
yeah.
come.
But the patient should be on follow-up.
Follow, yeah.
After the first year.
No, it's not stopping, but the follow-up, in the interest of the patient, not to come less number of times to the hospital, we can extend it. Now,
I would
yeah.
like to look at extension up to 4 months also. You can extend them rather than stopping it.
Stop.
I would probably look at.
I think as far as the AMD is concerned, we can't say stop because I think it continues. We have hardly very few patients. He also mentioned 20%. Probably the number is very small. Otherwise, they'll keep on requiring some treatment. DME is different. That's how probably the requirement for the injections in neovascular AMD is so much, which is not there for diabetics. The problem is diabetics will be stabilized after some time and they'll be okay. So that happens that we have seen that. At least I have some of my patients, those who we started treating in 2007, they have received in neovascular AMD more than 100 injections. I have
You see,
such
that is
patients.
true because
Yes.
diabetes has other parameters also which get controlled and the disease may get altered.
So I will just summarize what has been said. One is loading dose, yes, 2 or 3 injections, or until the macula gets dry. First few months, 6 months or something like that, you follow the patients very carefully to study the, behavior. And if the need for injections is quite frequent, then immediately shift them to TNE. Isn't it? That's a thing. And of course, depending on individual situations like a long distance, AFO and all that stuff, you can always modify this thing. Now this Q16, now, what percentage of your patients really reach that level where they need an injection only once in 4 months, 5 months? Is it 20%, 30%?
That happens only after the first 2 years.
2 years, yeah.
That is after the first 2 years.
Exactly.
So that stage is what I'm talking about.
Yeah.
There is a data called 8-year study on treat,
Yeah,
extend and
yeah.
stop.
Yeah.
8-year study.
Yeah.
And that is the highest. 35% had 15-letter gain, where they have continued treat and extend for 2
Yeah.
years.
Okay.
And after that, they have tried what I said, stop and frequent follow-up every 3 months, and they had that data. So when there is no end point for 8 years
Yeah.
treatment is
Yeah.
difficult.
Okay. And then last question, not directly related to this session, but any of you use brolucizumab as the first line of treatment in wet AMD? Any of you? Just to understand the practice pattern, that's all. None of you. None of you use brolucizumab as the first line. Ramesh is using. Okay.
Yes, sir. We used it primarily in PCV cases and in type 1 AMD cases. Yes, we have used it.
So do you give loading dose of brolucizumab?
Yes, sir. I give those.
Monthly?
Monthly 3 injections. 3 monthly, 3 consecutive months. Yeah.
Great. No artist will be happy. Of course, it's all individual, choice. I think, everywhere there's a generational shift. The way we think and the way the younger generation thinks is far different, Yeah,
But
that's the
Ramesh,
thing.
Ramesh is only type 1.
Yeah.
not type 2 membrane.
So, if you ask me, I will never repeat a prolizumab injection at the second time, not before 8 weeks. Minimum, I wait for 8 weeks.
So loading
And
dose,
after that only I inject. Huh?
Same
Yeah.
thing, same thing. I always give prolizumab as PRN
Yeah.
and never before it.
Yeah, so I never give, even if I have to
Because
give
most
the
of the
loading
side
dose.
effects, a lot of the side effects, IUI or whatever occurred
Yeah.
is what you were also saying,
Yeah.
increased concentration, increased molecules inside, is because of this frequent injections. You see, why is the difference in India is because majority of us do not give loading dose in prolizumab. And in majority of the patients, it's a second line of management and then the first.
That's what.
Having said that, predominantly in patients who have this membrane under the RP or PCV kind of structure, it is better rather than in type 2 or type 3.
So we'll wind up, sir.
Yeah.
Nice. At least between
We thank
ourselves.
all the speakers and the buyer for having us together here.